And with that, we'll go ahead and get started. Today, we're joined by Dr. Laura Miller-Graff, who is an associate professor at the University of Notre Dame and serves as the director of the William J. Shaw Center for Children and Families. Her research is the BRAVE Lab, which stands for Building Resilience After Violence Exposure. Dr. Miller-Graff's work centers on understanding how experiences of violence, especially during childhood, including the prenatal and perinatal period, can impact individuals and families over time. A big part of her research focuses on supporting women and children, particularly during pregnancy and early childhood, and developing practical, effective ways to help families who have experienced violence. She has worked internationally to adapt these supports for communities facing ongoing conflict and limited resources. We're so grateful to have her here today to share her expertise and insights with us. If you have questions, please put those in the chat. We will try to answer them today, but if we don't, we will attach the answers on the YouTube video. And with that, I will turn it over to Laura.
Hey, hello everyone. Thank you so much for having me here today. I'm excited to be with you and to hear your questions and have some conversations and share a little bit about the work that our lab has done in collaboration with many, many community partners over the years here in South Bend. So just give me 1 second. I'll get my slideshow up and running here and we can get started. Okay. Okay, so today I'm going to be talking about understanding intimate partner violence in the perinatal period and showing you some research evidence that can help us think about how we support maternal and intergenerational health in this context. So I know for a lot of you here, you'll be very familiar with what intimate partner violence is, but just to put us kind of all on the same page from the start. Intimate partner violence is defined as violence that is threatened or completed against a current or former partner. And this can include lots of different types of violence. So physical abuse, psychological and emotional abuse, sexual coercion and assault, and stalking. And a lot of conceptualizations of partner violence now also include what's called economic abuse. So a partner constraining or reducing access to financial resources or basic needs. In the United States, about 1 in 4 women experience intimate partner violence in their lifetime. These estimates, however, are largely based on the percentage of women experiencing physical and sexual abuse by a partner in their lifetime and don't typically include other forms of abuse. So when we look at studies that have a broader conceptualization of violence, we tend to see even higher percentages or prevalence of women experiencing partner violence in their lifetime. So it is unfortunately a common issue that we all confront in the communities that we live in. So a lot of people have asked me, violence occurs, of course, across the lifespan. Why focus in pregnancy? So one reason is that pregnancy represents a heightened period of risk for violence. So a recent meta-analysis, which is kind of a study of studies, gathering together data on intimate partner violence prevalence in pregnancy, shows that during pregnancy, the prevalence or how often intimate partner violence occurs is actually pretty similar to lifetime prevalence, which means that if we take that kind of like how many women have experienced in their life and slice it up into what developmental periods it occurs in, for most women, partner violence is occurring in pregnancy and those early childbearing years. So it's really an important time to support women and their families. We also know, and I'll show you some data here, that partner violence contributes to intergenerational cycles of risk. So women who experience partner violence often have experienced other forms of violence earlier in childhood. And we know that intimate partner violence is one of the best and most consistent predictors of whether women's children will experience violence or maltreatment at some point in their childhoods. So when we think about disrupting cycles of violence, intimate partner violence is a really important domain that we need to be thinking about for children and families. The last one is that the perinatal period is really a unique period in women's lives. And one of the things that got me kind of excited about work with pregnant women is that it's also potentially one of the best socially built-in kind of frameworks or times for intervention and support. So when you look at what we call service engagement, so how often people are engaged in some kind of formal support, right? Like going to a doctor, being enrolled in a class, something like that. In adulthood, pregnancy represents one of women's highest times of service engagement, right? So it's a real opportunity for them to be screened and supported effectively right at the start. In addition to this, and you'll see this a little bit in some of the data that I present, this is also a time of really massive developmental change for women, right? They're thinking a lot about what they want out of their lives, what they want for their children. And again, it's a time where we can really provide some additional support to women in ways that they're interested in. Okay, I'm going to try to cover a lot of ground here. So I want to give you kind of the big picture and then acknowledge that what I'll present to you today is just some small snippets of the big picture. So when we think about pregnancy and intergenerational processes, right, we think about humans as kind of multi-dimensional, dynamic, changing creatures, right? And so that's true for mom, that's true for baby. So I think about mom and what's called kind of the biopsychosocial framework, right? So there's biological elements to what is going on in pregnancy, there's psychological elements, and there's social elements. And then the same is true for the developing baby, right? And those, the relationship between mom and baby and how things kind of roll out over time is mediated by some of these intergenerational processes. So things like early breastfeeding, early parenting, family-wide functioning, ongoing violence exposure. And we can put a huge list here, right? So this is just kind of a snapshot. And all of this occurs in a community, in a society that has particular systems and structures and meanings that can either help support women and children or can be an interfering factor. Okay, I'm going to show you a little bit of data from, for the most part, our South Bend community, so you can see a little bit what is the case in our local context. So as I mentioned, it is really common for women who have experienced partner violence to also have experienced other forms of adversity in childhood. So this is data that's about half from South Bend, half from Memphis, Tennessee, as part of a collaborative study. And you can see here the prevalence of different adverse childhood experiences in a sample of women who were experiencing partner violence in pregnancy. So for example, you can see over half of women had experienced emotional maltreatment. A little under half had experienced physical abuse as a child. So we see here a lot of kind of compounding effects of traumatic events for women over the lifespan. And what we know is that the more kind of adverse experiences women have had, the greater their risk for psychological distress and other forms of difficulty during the perinatal period. But the good news is that we also know a good bit about protective factors. So I'll show you here, just to explain this graph a little bit. One of the things that we know is that social support and having reliable, high quality relationships with people you can trust is a very big protective factor in the context of exposure to adversity. And one of the kind of real challenges of partner violence is a lot of times women become very isolated as a part of the abuse they've experienced from their friends and family members. But what we see in our data is that, let me see if I can annotate here. Yeah. Oh, yeah, here we go. Sorry. That women who have higher levels of social support actually are protected from some of the negative effects of violence. So we see, for example, that women who have higher levels of social support have lower levels of depression and post-traumatic stress symptoms in the perinatal period. And that women who are experiencing housing instability, which we know is significantly associated both with partner violence and with mental health symptoms. If women have high levels of social support, so that's this gray dotted line here, we actually see that that is significantly protective for women in the context of housing instability. So for IPV exposed women, we generally see that higher housing instability is associated with higher rates of depression. And for women who have high levels of social support, we actually don't see that relationship. So it means that there's some kind of protective process going on there with social support. So social support is one really important area for support and intervention when we think about partner violence. When we think about intergenerational processes, we also want to think about how that rolls out across the perinatal period. So this is a study, I'm just going to read these here, that we did several years ago, looking at women's experience of physical violence in pregnancy and kind of its cascading effects over time. So what we found here is that women who had experienced violence in pregnancy they were more likely to experience depression at 6 months postpartum. And then 2 months later, those women were less likely to show what we call warm responsive parenting. So being attentive to children's cues, responding to them effectively, and with kind of positive warmth. And that in turn placed kids at greater risk for aggressive behavior when they were 2 years old. So we see kind of this, again, this intergenerational cascade. The important thing, though, is this also gives us kind of insight into what some potential protective factors might be, right? So if we think about this not just as a cycle of kind of risk or challenge, but also a potential cycle of protection, right? That gives us some leverage for intervention points, right? So we might expect, for example, that supporting women's mental health is going to have some natural benefits for their ability to be warm and responsive parents, right? And being warm and responsive parents is going to have some natural benefits for reducing child aggression. So it gives us some hopeful insights for intervention in that sense. Okay. We also found in one of our studies that breastfeeding appeared to be a protective factor in early infant temperament. So here we saw that for infants born to mothers who had been exposed to IPV, there was a negative relationship between IPV and positive infant affectivity. So it's basically like how bubbly, effusive, content babies are. And for women who were breastfeeding, that relationship was protected, right? So we saw breastfeeding kind of play this protective role of the potential adverse effects of IPV on early infant temperament, kind of social emotional functioning. So again, right, this provides us some really exciting and interesting insights for supporting intergenerational health for infants and babies. Now, I'm a quantitative researcher primarily, so we collect tons of quantitative data in our studies, and that is helpful and important in lots of different ways, but it's also really, really critical, as I'm sure you all know, to hear more qualitatively what women share about their experiences. So we've done a lot of qualitative work with women as well over the years. I just want to share a little bit about some of the themes that come up for them during pregnancy. So one is about parenting in the context of IPV. And here, it's really important to note that women express both some strengths and some challenges. And one of the things that we see coming up in our data actually is that when providers are asked about IPV in the perinatal period, they mostly talk about challenges. And it is challenging, right? And providers see kind of that very, very clearly. But it's also really important in our work with women to recognize all that they are doing well to support their families. So here we have one mom saying, I think that maybe victims of domestic violence, maybe they're a little more sensitive, a little more compassionate, nurturing. I've become an excellent nurturer, a lot more patient. And then on the other hand, we have another mom sharing that her husband yelling at night keeps her up It interferes with her sleep. And she says, my son, when he cries, I want to hold him. When he was a baby, he'd say, this is the dad, you can't hold him, you're spoiling him. And that's hard, right? So we see ways in which violence is creating kind of a clear interfering factor in mom's parenting. We also have moms reflecting on leaving the violent partner, and this is something that we see a lot in the groups that we run, as well as in our focus group data. Women, as I mentioned, are at this developmental juncture where they're really trying to decide, like, how involved do I want, if dad was the violent partner, dad to be. So we have here a woman sharing, some sense of empowerment. So women are self-sufficient. We have support. There are more resources than ever before. So you can take advantage of those to change your life. And that's a parenting gift you can give your child, right? So we have women really thinking in meaningful ways about that transition. Also recognizing the struggle. So we have another woman saying it's weird to detach yourself from somebody who has so much power over you. People will get that first phone call telling you they're not going to do it again, and within a week it gets worse, right? So we have kind of some thoughts about the cycle of violence and the difficulty breaking from that. We also have women talking a lot in pregnancy about these intergenerational processes that they've experienced and also fears for the future. So we have here one mom reflecting on the fact that she grew up in a home where partner violence was present, and another mom reflecting about the implications of partner violence for her kids, right? So expressing fears that her girls, she says, are not going to know how to choose guys, and that the boy hasn't seen guys that have treated women well, and seeing kind of anger problems or being concerned about that, right? So this is really at the forefront of women's minds. Women also talk about their perinatal experiences. So we have one here. This is a pregnant mom talking about how her partner, when she was on bed rest, kept telling her that she was a liar, that she wasn't really supposed to be on bed rest, that she was just lazy. And we have another mom reflecting kind of on some economic strains, right? So I got home from the hospital, left straight for work, and then started hemorrhaging as a part of that. And, then came home and experienced violence as part of that episode. So, we have a lot, as you can see, that biopsychosocial model is really important, right? So all of these things that moms are reflecting on, there's social elements to it, there's biological elements to it, there's broader kind of cultural, structural, economic elements to it. And we really need to be thoughtful about how those come together in the context of the intervention or supports we provide. So I'll speak really briefly about some intervention work that we have done in South Bend. This is in collaboration with Dr. Catherine Howells, who's at University of Wisconsin-Madison. But this work was actually done when she was at Memphis. And we use some of this data that I've just presented to you to help develop a program called the Pregnant Moms Empowerment Program that's specifically attuned to the needs of pregnant moms who have experienced partner violence. We have, it's a 5-session program. It is broken up into 2 kind of core modules, one that focuses on violence and mental health, and one that focuses on perinatal health and early parenting. The data I'll show you today is with 137 pregnant women who had been exposed to IPV in the past year. About half of these had come from South Bend. We had a very racially and ethnically diverse sample of women. And most of these women considered themselves single parents. And so they're, either they might be first-time parents, they might have other kids, but the majority of them are single. And partner violence exposure was quite high. So on average in this sample, we had women reporting about 167 events of partner violence in the past year. So, roughly every 2-3 days, if you think about it in that framework. At baseline, we also saw pretty high levels of psychological distress. So 67 to 74% of women were in the clinical range for either depression or PTSS or both. And that's pretty consistent with national estimates. These are really common mental health outcomes for women who have recently been exposed to partner violence. I can go into more depth maybe in Q&A about how we did this study and how we evaluated it, but I'll get to the good stuff and tell you what some of the impacts were. So for women who participated in the program, we saw significant declines in partner violence that were sustained across time, and that was especially consistent for physical and sexual IPV and for women who attended more of the sessions. So the effects got stronger, the more kind of they participated in care, which makes sense. I've highlighted here, these are just the average number of events at kind of each wave of the study. So you can see if you look here in this first column, we have our treatment group on the left and our control group on the right, and you can see where the differences are emerging. So we have, for example, significantly lower rates of violence-related injury at the third wave, which here is 3 months postpartum in the treatment group as compared to the control group. So we were pretty excited to see these changes. We also saw positive impacts of the treatment on mental health. So moms who participated in the Pregnant Moms program had significantly lower rates of depression in pregnancy immediately after they had done the program, as well as at the 1 year postpartum follow-up. So again, we're seeing really nice sustained effects of participation in care, which we were excited about. All right, and parenting. So we saw for moms who participated in PMAP that they had more what we would consider called developmentally appropriate expectations of their children. So they have a better sense of what children can do at the age they can do it, and they had higher levels of empathy. We also saw that moms who participated in the program had significant positive changes in their observed sensitive parenting. So we actually brought moms in and we video recorded them playing with their infants. And at 1 year postpartum, when infants were 1 year old, we saw that moms who were in the intervention were using more sensitive warmth in their play with kids, which again is pretty exciting to see. We're working now on some analyses that are focused on the intergenerational impacts on infants. This is a complicated model, so I'll break it down because it looks a little bit like a mess right now. But basically, we saw for moms who participated in the program, when their depression reduced, so we saw lower levels of depression in pregnancy post-test. For those moms, we also saw lower levels of negative, what's called infant negative affectivity. So lower levels of fussiness at that 1 year mark, which is pretty exciting. And we also saw that reflected in observed infant affects. So again, when we brought the moms and the infants back in to play with them, we looked at how were the infants enjoying play? Were they laughing, giggling, crying? And infants who were born to moms who participated in the intervention had more had better infant affect, particularly mediated in this case through mom's reductions in IPV exposure. So we do see evidence, just as we saw at the beginning of some of these kind of cascading pathways of risk. We do see that when we support and intervene on those, we see cascading protections as well, which is really exciting. In terms of long-term effects, we saw at a 3 to 4 year follow-up sustained reductions in partner violence for women who participated in the intervention. So had a little less than half of the rate or the frequency of IPV for moms in the intervention group. And then we saw sustained improvements in depression. So our moms in the intervention group were significantly lower on average, and that also translated to a significantly lower number of moms being in what we would consider kind of like the clinical range of distress, so really high levels of distress. We also saw that children born to PMAP moms had significantly lower levels of externalizing behavior problems when they were 3 to 4 years old. So tantrums, hitting, aggressive behavior, defiant behavior, that kind of thing. So also, really, really exciting that we're seeing these sustained effects. I want to turn to, how we, as we get in our last couple of minutes here, can support women and infants, right? So this is the program we have developed is one way, but there's lots and lots of others depending on your area of work and what the ways in which you touch women and children in the perinatal period throughout your work. So one way, right, is screening. So if you are a service provider who interacts with women and children and you have opportunities to make, strong referrals or provide specific supports, screening just to know whether or not IPV is occurring in those families is really helpful. So I put here the abuse assessment screen. It's not a super detailed, comprehensive assessment, but it is quite good overall in terms of its quality as a screening tool. So that's actually what we use for our very first initial screen. That can be a good tool to use for providers. Also, right, particularly if you pick up screening, you need to think carefully about your response. So, if we think about, again, that biopsychosocial model, where do you fit in that framework, right? What are your capacities? No one can be everything and meet every need for every person, right? But thinking about where you might be able to respond or support and contribute, and then how you can refer and network to help support women and children is really important. Another really important note is just related to safety. And I always like to say this, particularly in the context of screening. So we know from a lot of research that the time of highest risk for women in terms of lethality risk of partner violence is when they are leaving the violent partner. And so it is really, really critical not to jump right to well, you should just leave, right? Without the appropriate support, without the appropriate safety planning in place. So safety planning for women is really the first step before there's any conversation about what's next. We can talk in the Q&A about mandated report, but obviously when it comes to child safety, that is something that often enters into the picture in the context of service supports. That can be really challenging for providers, but supporting women through that process can also be a really formative experience for women and their families. And then last, I will also say, provider reliability, establishing a strong sense of trust and positive regard are ways that, we all can support women and children exposed to violence. It's really can be difficult to trust providers. It can be a challenge to share these difficult experiences or to figure out how to navigate next steps. And we can really support women well when we pay attention to that aspect of our relationship. Okay, I will close there. I only gave us 1 minute, so sorry about that, but I'm looking forward to hearing some questions.
We can go ahead and we'll wrap up the recorded portion of the video and we'll add any question and answers to the YouTube video in a written document. So thank you all for those who joined us on live and are viewing it on YouTube.